Dr. Elaine Tierney is here to talk to us about extreme SLOS behavior and use of medications. As you all remember, she's a research scientist at the Kennedy Krieger Institute and an associate professor of psychiatry at the Johns Hopkins University School of Medicine. Ladies and gentlemen, Dr. Elaine Tierney.
Thank you. Very good. Okay. All right. So Julia O'Connor, the behavioral psychologist, is going to follow after this lecture. So I won't go into too much about that, thankfully. So lots of other things. So Julia, of course, ideally, if you are able to get a behavioral psychologist to assist, and I know it's really hard getting care, finding people, but a lot of it, and the lecture today is more on extreme behavioral aspects. So ideally, a behavioral psychologist can be part of the team and a speech and language pathologist to figure out if the behavior is related to communication and for other functions such as wanting attention. So I also, as a physician, I try to figure out, is there something else going on, particularly if it's a change? All of a sudden your child's hitting their head, then you wonder, is there an ear infection, a toothache, a headache? Are they starting to become ill with a virus and they just aren't exhibiting it yet? Sometimes behaviors can be related to GI issues, gas, constipation, reflux, sometimes seasonal allergies. Sometimes the frustration may be the demands are too high or too low for the individual's ability. Having a communication challenges and the frustration that can go along with that. So much of behavior in SLO is has a communication function. The behavioral psychologist Julia will be talking about function a lot. And then seizure disorder, which is not common in SLO, although some people do have it. Sometimes sensory issues could be moving the head side to side or rocking. Some sensory things. Sometimes one is able to use sensory toys or movement, swinging, different things that can help with that. Sometimes environmental factors, like any typically developing individual, maybe we are at the end of it, at the end of the day, and we work there, kind of exhausted and irritable a little bit. Sometimes the task is beyond one's ability to do. And then Julia will talk about environmental reinforcement of behavior, meaning something's going around, okay. And if a family or staff changes, individuals with SLO often have a difficulty with change in routine. I know it's extremely difficult sometimes because there can be change in the school setting and one doesn't know what's going on. So as a psychiatrist, I also try to look to see or conceptualize behaviors for a couple of reasons. One, it helps to give me some guidance to know what kind of behavioral intervention can be done, as well as what kind of medications. For example, with the attention deficit hyperactivity disorder, you might have an individual in the front of the class. Individuals with milder SLO tend to have ADHD, and sometimes you can have things to fidget or little seats, something that goes on the seat of the chair that you can move. I also look to see if there's a mood disorder such as bipolar disorder, or they invented about 5 years ago a new disorder called disruptive mood dysregulation disorder. And I say invented because there's probably, one day is 100 years from now, we'll know all the different disorders and maybe blood tests. At this point, we just try to look at what the picture of what's happening, what is the person doing, and that guides us. But sometimes there's also Also illnesses that run in families. Maybe if the parent has bipolar disorder or a grandparent or sibling. Kind of if we can identify that, then if we need to go to use some medication, we can be more specific about it. Obsessive compulsive disorder, where one has to do something in a certain way and be upset if it's not done. We see that in SLOS as well as anxiety symptoms. Selective mutism, should say will talk at home. Usually that's where an individual will talk in certain situations, but not in other situations. And disruptive behavior disorder, I don't think of that as so much a biological disorder, but you're talking about kind of symptoms. Okay, so in the packet that I've given you is a very nice a packet called the medication decision guide. It's one of the Autism Speaks what they call toolkits. So if you Google Autism Speaks toolkits, you'll see they have about 50 different toolkits. IEP, you want an IEP, transition planning. I know I mentioned them yesterday. So how I approach behavioral issues is that what's essential is to get a behavioral mental health provider, such as a behavioral psychologist, who can help to figure out what the behaviors are. So, but then one goes on, when should one use a medication? And the guide is very good. I'll go over a little bit with the guide, but it's extensive, the guides that I have given you. But as a psychiatrist, I think this is how I do it. I think there's one of three reasons usually to use a medication. One is the individual suffering? Is the individual a danger to himself or others, like doing self-injury? And they're biting their skin and breaking the skin. They're hitting their heads, which is so important. And I'll address the head injury in a minute. Or are they impaired in school or their home life or in their community? And I know I'll put in the slide again, but I always emphasize if one's going to use a medication, it's a trial. And I tell parents, it's a trial, and it's up to the parent to decide if they see enough benefit to keep using it. I may think they're benefiting, it doesn't matter, it's what they want to do. It's a trial. Okay, so this is one of the things in the medication guide. I know you can't read it, but I just wanted to say what's on it, and we'll go through it. So it's part of it is it's a considering personal belief benefits and risks, and help one to guide leaning toward choosing medicine, don't know, or leaning away, such as child's behavior is not causing problems at school. So to help one kind of go through and think through, and personal values, how important it is to the parent. It's up to the parent to do. Such as I think my child could feel better. Is that important? Not important? And it goes through these things, and then has one reasons for not giving your child, such as I'm worried my child might have side effects. I'm worried that there might be long-term side effects of the medication that have not yet been discovered. So there's lots of reasons not to use medication. And then what are your options? I could work with my child's healthcare provider and have my child take medicine to treat behavior. I could discuss medicines and other treatment options, such as behavioral psychology, speech and language pathology. Okay, so in the guide again, so it's in there, so you don't have to worry about this is straight out of the guide, but I wanted to go over some aspects. It's really nice because you take time ahead of time to write these down prior to work on it prior to seeing the physician. And the questions are, what are the behaviors that you're targeting? And generally in SLO, it's often severe self-injury, and maybe ADHD. How long will it take the medication to work? What are the possible side effects, and how common are they? A lot of time the side effects, I'll talk about side effects, and the side effects of medications can often be quite beneficial, such as if the medicine tends to make you sleepy, then we might give it in the evening. You want to know, are there FDA advisories? That means there's things called like a black box, and it's listed in the handout, meaning that there's certain things that are dangerous about that medication. I do want to say there's a black box for antidepressants saying that they can increase suicidality. They've actually come back and found that, well, once they put that black box out and pediatricians stopped prescribing antidepressants, there was a much higher rate of suicidality. But suicidality, it is important. It's more generally people who have bipolar disorder when they first start the medicine, and with depression, because what can happen when you're treating depression is the mood is the last thing to get better, but your energy and your ability to kill yourself. I mean, it's not so much an SLO, but wanting to explain, talk to the doctor about the black box and say, what does this mean? How does that black box actually apply to me? And these medication got a lot of these things can be for not just psychiatric medications, but in preparation for seeing your geneticist or pediatrician. What are the blood tests that need to be done? And if your child has a really hard time with blood tests, that sometimes will lean us toward using one medicine versus another, because with some meds, we do have to give blood tests, and so some you don't really need to. And how do you decide if it's helping enough? And again, that's kind of talking to the doctor and part of your assessment to figure out, do you think it's worth using the medicine? Are you seeing enough benefit? If it's a little benefit, maybe it's not worth the potential side effects. Is there information about the medication I can take home to look at? Hopefully, you can get a lot on the web. Can you write instructions for me? That would be great, because the bottle that you get, it may say something different. It may not give enough information, particularly if you're giving it with formula. Want to check to make sure that the form that you're going to receive is the correct, is your child going to need a liquid form? If it's a tablet that can be crushed, can that medicine be given through a tube? Not all medications can be given to a tube, because it'll stick to the tube lining. What else should my family or school team be doing to help? What happens if you take too much medicine or miss a dose? Of course, I always tell people just contact us to check that, but it's helpful to know if you can't reach someone. Are there vitamins, medicines, and supplements that affect this, such as we worry about with a lot of our psychiatric medicines? If you're taking an oral, medicine by mouth for fungal infection, there's a couple of other medicines you have to be careful about. How do I explain the medication? Should I tell the school about the medication? How often should I come back to the clinic? If you're going to be in a clinic 5 hours away, or your work schedule is going to interfere with the work schedule, you might want to assume maybe the doctor, maybe can we use the medicine? I don't need to come physically to get the blood test or be seen as often. Okay. And then if it's helpful, you can ask the doctor, if it's helpful, how long do I continue to take it? Most of our psychiatric medicines, they're the type of medicine, unlike an antibiotic, which will just make the condition go away. Our psychiatric conditions, unfortunately, they often continue. But sometimes if one has, if you're treating major depression, the illness gets better after you treat it. But generally, I'd say for our behavioral medicines that I use in individuals with SLO, it's something that's going to be an ongoing thing, or at least for a while. Sometimes I know it's really hard to get services, Dr. O'Connor, you'll be able to reach her. You can email me at any time. Julia's going to tell you that you can email her so we can help you get set up with behavioral people in your area. Sometimes I'll talk to parents about, okay, you're going to be going into our inpatient unit, you're getting behavioral services. We could do this maybe more as an emergency measure to keep him safe or her safe, with hopefully knowing that we're going to be being able to get a behavioral team, because it does take such a long time and frustratingly long time to get a behavioral treatment in place, and maybe providers that can help you at the home. So medicine can be maybe a temporary thing. It doesn't need to be lifelong. Maybe during puberty, the couple of years that you kind of are dealing with crises, or if there's a family situation or crisis that you just need something temporary, particularly if you're going to choose a medicine that doesn't have as many long-term side effects. How quickly can the medicine be stopped? So it means, do we have to wean it over a week or two? Most of our psychiatric medicines, if you stop it, you're not going to have a really bad side effect. You might get a stomach upset, diarrhea, or feel uncomfortable. So we do prefer to wean if it's a medicine. Some of our medicines that we use for behavior things, such as Depakote, valproic acid, that does need to be weaned because it also treats seizures. And if you go off it cold turkey, you can induce a seizure. So it's always a good question to say, you know, how should I wean this? And then any decision guide, any other things you can think of, you can write on it right there, and then bring it with you. There's a second guide in the handout you have that's behind you. So the first one is kind of like, should I use it? Should I not? And some things I said, but in there's an extensive guide as well that will help you write down target behaviors so you can look at it ahead of time and think of the behaviors when you go to see the physician particularly. I mean, it's really hard. I know it's like so hard to find a child psychiatrist. There's a huge shortage, or a behavioral pediatrician, and hard to get behavioral psychologists. So I know a lot of it is on you kind of recording, figuring out what behaviors am I going to look at. It's one of the things that is so incredibly important to me as a provider is of course, I'm trying to figure out if somebody is getting better. So parents who take data, I love it because I want to know how often did they do it? Did it get better? None of us remember these things. I mean, I think it's part of the wonderful thing about being human is we can help forget the painful moments. But as a psychiatrist, I want to know, and I'll have some people come in and say, like one person said, oh, I never thought of suicide. I'm like, well, actually here you had a plan of so-and-so and we started medicine. I'm like, oh, so the more information you're able to gather and write down, record, how often is this happening? When is it happening? What's the frequency? That's going to be really helpful. And Dr. O'Connor will talk about that as well. So some of the things, there's sheets in there about managing daytime sleepiness. Will it get better? A lot of our psychiatric and neurology medications, you get initially a little bit sleepy and that goes away. I actually find it extremely helpful. And I work full-time in an inpatient unit. I'll flip dose times around some of the medicines. So a lot of our medicines, if you're too sleepy during the day, they're not sleeping well at night, I can flip it to the evening. Depends on the medicine. So I often use those side effects to benefit the individual. Lists a lot of foods, may not as particularly here, but it does list food and calories, proteins, and other nutrients. I know individuals with SLO are very food selective often, and you're trying to get high cholesterol foods often. And then it goes through some of the various medications and potential benefits and side effects, which I'll talk about as well. And there's some tips on pill swallowing. Okay. All right, so, and it mentions kind of some behaviors and symptoms that might get better with medicines. Some of the things we look at are overactivity, physically running around, short attention span. If someone's impulsive, they do something without thinking about it, without thinking about the consequences. And this is all in typically developing individuals as well. Irritability, aggression, self-injury, those are the kind of things that might get better with medications, kind of things we can target. Tantrums, repeating thoughts and behaviors, sleep problems, tics and anxiety and mood instability. It can be depression, as we tend to see, or irritability. Even in typically developing children and adolescents who we diagnose with major depression don't have sadness. Their mood symptom that presents is boredom and irritability are the mood symptoms rather than sadness. So the things that the guide says do not usually follow directions. Now, although my part I added, if you're dealing with ADHD and it's very hard to follow directions if you can't kind of process it. The other thing in SLO, and sometimes we have to remind the schools of this as well, is that individuals have, usually with SLO, have a better ability to hear and understand than speak, but it's still delayed. So you have to give them enough time to process. We call it slow processing time. So sometimes you end up repeating 3 times, but sometimes you just say 1 time and you give them enough time to respond. They need a little bit longer to process it and respond either with a board or by word. So, and if somebody has a mood disorder, they're irritable, they're angry, they're non-compliant, that can be a reason for not following directions too. Refusing behavior, Dr. O'Connor will talk about, a lot of these are like refusing behavior is kind of classic. Dr. O'Connor will talk about the behavioral psychology aspects of that. Slow learning, or cognitive difficulties, those are medications, don't help as much unless maybe you have ADHD. Sometimes if you could attend better in school and also get better school accommodations, make sure your child is in the front row, to get enough services, that can help with the learning. Our medicines, we don't unfortunately have any medicines that help with the not talking or low communication, unless maybe you're focusing on attention a little bit better and giving them more time. But in general, my medications don't help that and don't help poor social skills too much either. Okay, so one of the things when I consider using a medicine is the child doing damage or potential injury? And they can, head banging can damage the head, damage the hearing. The other thing is in the back of the eye, we call it the retina. That's the back of the eye where the messages go through the eye and to the brain. So that can come off. And it can happen in anyone at any age, even if they don't head bang. So if you ever think that someone is starting to, they can't see as well, or you ever see like a curtain coming, it's an emergency. You have to go to an emergency room, preferably an eye emergency immediately. Sorry. That makes me cry. So we've had so many children on our inpatient unit who are blind. We had 2 girls recently, and they're on the same time because of self-injury. But we did have one recently we sent over to Hopkins Eye, and she had partial detachment. You can reattach it if it's partially detached. And every time I think of her, I cry. So, and you wonder, well, how can an ophthalmologist see, see the retina? They're able to do ultrasounds that can tell them if the retina is attached or not. So that's one of the things that I wait with parents about. Do you use the medicine for self-injury? It's the eyesight. I mean, it's just so yeah. So that's one of the reasons I recommend it. Okay, so I said this before. All medications are trials, and it's up to the parent to decide to use it. And do you see enough benefit? Do you have decrease in head banging? Because I think that is really, we have to be very aggressive and know that individuals can become blind from self-injury. You can do, even one hit can make someone blind. And if you have something like nearsighted, farsighted, so the eye isn't as round, the globe, as it usually is, that puts you at higher risk of retinal detachment as well. So all medications are trials. Medicine may not help, or you may need to go through a lot of different trials of different medications. Medicines can cost a lot. Harmful side effects can happen. So you want to talk about what are the side effects that can happen. And it may require ongoing trips to a doctor, which I know are very difficult for some people, depending upon where they're living and what resources they have. So what are the possible benefits? It might be less irritable. Behaviors might improve. You might get decrease in self-injury. And depending on what behaviors I'm looking for, depending on the symptoms and how I conceptualize it, it guides me as to what medications. So it might sleep better, and family stress and relationships might improve. Okay, so antipsychotics. So antipsychotics, we use them in autism. We use them in individuals with SLO. They treat aggression, disruptive behavior, self-injury, which of course is the head banging primarily I'm worried about. It can decrease the hand biting and arms when I've used it in individuals with SLO, although that's such a driven behavioral issue. I think of it as like an internal drive, and when it frustrated going to the arm. So you often use, I know I've mentioned Kevlar sleeves. I have one patient who loves the Orioles, and he has Orioles Kevlar sleeves. And you can wear gloves. Julie will talk about those as well. Kevlar gloves or like a batting glove, like a baseball glove. You have a Velcro hold so you can't pull them off. It treats ticks. I mean, if someone has ticks are very common, like eye blinking, some movements are very common. We generally don't go to an antipsychotic. That's for someone if they have more severe ticks. And I just put up some of them. I don't know if you can read it back there, but you might recognize some of them: risperidone, ziprasidone, olanzapine, quetiapine. I listed up here the ones that are more likely. Cariprazine, Vraylar also increased 7-DHC levels. So one of the things, these medications can increase 7-dehydrocholesterol levels, which we don't want that. So we preferably try to use one that isn't at least known. But 7-DHC levels in the skin make you more photosensitive and more easily to burn. So do our psychiatric medicines. So for me, I think if that psychiatric medicine is known to cause sun sensitivity, it's probably related to 7-DHC, because the researchers haven't been able to test all of them, and it's a little harder, in doing in the research. But we have decades of knowledge of knowing which medications cause photosensitivity or more easily to burn. So some of the side effects are sleepiness, drooling, increased appetite, and weight gain. Some of these can be helpful. If you're sleepy, give it in the evening. All our antipsychotics are pretty long lasting, so you can give it any time during the day. You can split the dose. Sometimes I split it up, so I'm targeting difficult times. I'll ask parents, well, when is it most difficult? So you can always ask the doctor to move these times around. Usually it's not a problem. Less common are high blood sugar, increased cholesterol, which is not a bad here. Some of the there are some eye side effects. Some are like blurred vision. It's just while you're taking it, it's not permanent damage. Although the other eye, some of the oldest antipsychotics can do some like pigments, some darkening where you can't see as well over time. Ziprasidone heart side effects. It's more we get EKGs, and I know they're hard to get often. For some of our medicines affect some of what we look on an EKG. You can see it affects the speed, essentially, of message going one part of the heart to the other to coordinate the pumping of the heart. So those are all things to think about. So here again, just talking about the 7-DHC and the photosensitivity or sunburning might guide you as to which medications. And when we get to the antidepressants and others, I'll mention, you'll see that again. So what are the antipsychotics? So the other antipsychotic movement disorders. So there's different kinds of, so they call them extrapyramidal, just means a part of the brain it refers to, and you can get different movement aspects. Some is a temporary muscle stiffness called dystonia, which is it's not permanent, it's not harmful. When you stop the medicine, it goes away. But there's permanent movement disorders. You can get like a movement of the mouth or other parts of the body that if you use it long term, even if you stop the medicine, it doesn't go away. And we found in individuals with autism, they seem to be more sensitive to this. I get this a lot, at least that it shows up. We usually stop the medicine. You have to weigh it. I mean, what's the severity of the behavior? Can we stop the medicine? Can we switch to a different? If I really need an antipsychotic, or I'll try to use a medicine that will maybe allow me to lower it or not use it. You have to weigh that with the doctor, or use one of the newest ones that may seem to have less of that. Although we find, like when the family of risperidone came out, they said, oh, it's going to be much less chance of this, but it turns out there's still a lot of tardive dyskinesia. So the other thing to know about these antipsychotics that people don't talk enough about, the doctors, is you can get a life-threatening thing that happens called neuroleptic malignant syndrome. So if your child looks very ill, they have a fever or chills, blood pressure increases. Oh, sorry, him. I use dragon when I breathe. It types him. I missed that one. So I'll do it. You write something and then I'll do search for him afterwards, make sure it didn't get in. So, but it's really important to know because you want to stop the medicine and get intervention right away. It is life-threatening, and if you don't recognize you can die from it. It actually is. It does happen. So that's something important to know about antipsychotics. A couple of medicines, you're able to get blood levels. So I work full-time on an inpatient unit, and we have so many children who come in, and they'll come in, they have severe self-injury. They come in on a 0.5 milligram or 1 milligram of risperidone. It's not enough. It varies for the in the end. So you're, of course, the gene that's affected in SLO causes a problem with an enzyme, just means a protein that causes a reaction anyway. So the liver breaks down a lot of medicines. One of the main medicines that, for example, that breaks down psychiatric medicines, you can have anywhere from 1 to 11 copies of genes. You could have some people who metabolize it very quickly and need a high dose, and others who don't. So I'm able to get blood levels. I have this little boy, tiny, he's on 4 milligrams of risperidone. He's an equivalent. You get the blood level, it says you're an equivalent of an adult on 3 milligrams. So if your child's not responding, usually I say, if you're on an antipsychotic and you push the dose, you're either going to get a side effect that makes you worse or makes you sleepy. But if I don't see any sleepiness and there's no side effect, push the dose. And again, you're weighing. I've seen so many people who their children weren't helped enough because the doctors were hesitant. And you can say, can we go up on this? Let's do a trial. I know we don't have to continue, but if you see the benefit. So I will go past so FDA indications, when they talk about FDA indications, all that means is that they've taken a study and gone to the FDA and said, this is the range we had. For example, I was one of the sites, one of the principal investigators for the study for risperidone for autism. Later, the drug company, it was an NIH-funded drug company, came back, got our data from us, and went and done an indication. So they're using the doses that we had chosen for our clinical trial. Your child may need a lot more. So an indication, it will help guide a physician who isn't familiar. Of course, the physician, contact me. I'll give the physician my cell phone number. We'll talk. They can contact me 24 hours a day. Often, if they just have a psychiatrist they can talk to and say, no, go higher. It's not a problem. Just watch for side effects. They'll go do it. So, but sometimes it's helpful, and they'll go, oh gosh, okay, no problem. Because the physician, our rule is do no harm. So we don't want to harm. We don't want to cause side effects. We don't want to make something bad, but we also want to make sure that we're helping the person, particularly if they're doing self-injury and they're at risk of losing their eyesight. So obsessions and compulsions. Obsession is a thought that comes to you. Compulsions, when you have to do that thought, they're normal. Most people have 1 or 2. Maybe I'll go check that door one more time. We don't consider anything, these things in life, we don't consider them a disorder unless they impair you or distress you. You can have all the compulsions you want. They don't bother you. It's not a problem. But in SLO, it can be really a problem. It can be repetitive. There's behavioral interventions. Julia can go over about, you try to block it, you try to give them, distract, and maybe try to do a variety of things so you don't get stuck on some things too much. But sometimes they can impair or distress. One boy with SLO, actually, I guess he was a teen at that time, would have his parent hold his device because he didn't want to break it. And when he did get it, he broke it. He asked his mom to come into the shower because otherwise he'd take the door off the shower every time. So we do use antidepressants for those. Sometimes if it's severe enough, we'll use a little bit of antipsychotic as well if necessary. Opening, closing doors, turning light switches. So what does one consider an obsession, or what is it in SLO repetitive behavior? It's kind of, again, all these things are artificial. They're just saying we're giving a name to something. Sometimes thinking about it as an obsession compulsion guides us. And we do find in autism as well, repetitive behaviors can respond a little bit to these antipsychotics. It's not great. It's a really strong drive. But if it's impairing enough, and again, hopefully doing some behavioral things as well. But yes, it can be very impairing, very distressing because you end up doing a severe tantrum if you're not allowed to follow through with the behavior that you want to do. It does seem to be more in teenagers and adults with SLO. It might be also as you get older and gain more skills in communication and understand things more, maybe you're expanding your realm, and it's not just one toy, but you're like emptying that bottle you want to do, and you're getting more skills, and unfortunately also means more ability to do things that can be problematic at times. So we use antidepressants. If there's a family history of bipolar disorder, you want to be very careful using an antidepressant. If you biologically are predisposed to it, it can make the illness come out. Same thing if you have a major depression. 2/3 of people who have who end up having bipolar, their first episode is a depressive episode. You don't know you have bipolar until maybe you're put on an antidepressant, you flip into bipolar disorder. We do cognitive behavioral therapies are our first line of treatment. You try to stop yourself to doing it, let's say as an adult, or and it works. It changes chemistry in the brain. Now we think it changes the wiring in the brain, just as we think behavioral intervention that Dr. O'Connor will talk about. We think about that as changing the wiring in the brain. But I did mention some of the ones that we know. Those I said approved by FDA, that means for children. It's wider, but meaning again, somebody did a study, then went to the FDA. The majority of medications used in children for psychiatric and non-psychiatric have never had studies in children. And because then once they're off, they're no longer on patent, no one's going to spend the money, and NIH doesn't want to spend the money either, to go in and do a study, which are very expensive, to tell you that it works when you're already using it, and all the pediatricians are using because they know it works. So FDA indication, the majority of medicines I use have no FDA indication in children. So just to kind of explain that. So those are ones that have been shown to work for OCD in children and adolescents, but other antidepressants might work as well. And again, it's trial and error, unfortunately. And I did give you a printed copy of this lecture. So fluvoxamine, when I have to choose one, fluvoxamine I don't like. It really interferes with the metabolism. The breakdown of other medicines can make other levels go higher. It works, but if you're on like an SLO, you tend to need other medicines. It's not my first choice. Lexapro, even though it doesn't have studies, it works and is less likely to interfere with all other kinds of medications that your child are on. There's a really good website. If you Google, I didn't put it up here, Indiana, P450, you go in there and it lists all the different enzymes, and you can tell your doctor if you don't as well. Indiana, and then P450 is what I Google, and it goes to a website that gives you all the medicines that are broken down by the different enzymes. And enzymes meaning like in the liver, you have these different systems that break down different medicines, and you can look at each one's alphabetized. You look for your 2 medicines and see if it's on there. And if one's ever had these kind of psychiatric gene testing, all it is telling you whether you break down medicines fast or not. But you can call me too, or email me, and I can help you with that. Fluoxetine Prozac has been shown to increase 7-DHC levels, so maybe a good reason to not do that one, and go for I would go for Lexapro, usually escitalopram. Okay, medicines for anxiety. Valium, lorazepam, they can help anxiety and agitation. It's not usually our first line medications because you end up getting your body gets used to a little bit when you have to push the dose. The other thing, it's a controlled substance, so it's a terrible pain to try to get it from your doctors. And but some of these medicines in this class, benzodiazepine, it's the class all these are in. Sometimes they do treat seizure disorder. What I didn't put on here is they also can treat catatonia. We spoke with someone from another country today who looks like their child might have catatonia. My colleague at Kennedy is the world's expert in catatonia and autism, so you can always reach out to me, and I'll when I have questions, I go to her. And we do have a lot of children on inpatient unit who come in with catatonia. It's not something I've seen in SLO, but I've never asked the question enough, because it's kind of a weird thing, right? So catatonia, you think of not moving. It's agitated catatonia is what we see. You get repetitive self-injury. Is what we see. It's not so much an SLO, but I also haven't looked enough. I guess I need to. I'm reactivating my research protocol so I can aggregate data. I don't have a means to like record information on people. I'm not allowed to do that unless I have that. I know these HIPAA rules and privacy. Because I'm a researcher, anything I do, you know, they're going to say, oh, you're going to benefit it for research too. So that is almost reactivated. And I actually do have, I did get, it just came through like 2 days ago. I do have a consent form that allows me to record your contact information. So anyone who's interested in research, I have those. I can sit with you. I'll just say the consent form. The first thing basically says I'm going to record your contact information, and after that, a huge template, which is our attorney speak. That's all. It says all kinds of things that have nothing to do with me recording something in my Excel spreadsheet. I do keep it safe. It doesn't go on my computer. It can't be moved. It has to be on the server at my hospital. Okay. So bupropion Buspar is one that's used for anxiety. Sometimes I never find it helpful anyway, but it does increase 7-DHC, so that's one I tend to avoid. Depressive disorders. Sure, maybe I put that in twice. So depressive Prozac and bupropion are known to increase 7-DHC. So again, I don't use citalopram as much, Celexa, because it does interfere with the metabolism of other medicines more. Again, I would go for Lexapro if your doctor's going to go for an SSRI and you're on other medications. And again, this printout is in your packet. There's a copy of all these slides. Okay, all right. So some people have there might be a seasonal component to the mood. So you can use a light box. You can buy them on Amazon, but talk to your doctor. If there's bipolar in the family, a light box can activate bipolar. So be careful about that. Exercise is helpful for everybody with the mood disorder and anxiety. Everybody should exercise. You have your child exercise, go on these long walks, go on your something that's sensory that help wear them out, maybe give you a break at the same time. Fruits and vegetables, if they eat those, that's always good. And avoiding sugar and excess carbohydrates are important for mood disorders. So bipolar disorder, I've been mentioning that. It's also known as manic depressive. It's a very common disorder. Like in 1 to 4% of the population. Maybe angry and irritable. You don't have to be happy to get cyclical mood disorder. You can just go from okay to irritable or okay to unhappy and depressed. Some people never get the mania or hypomania. There is something called disrupted mood dysregulation disorder. The reason they invented that is they were using bipolar disorder. So these criteria are all just people sit around a room and say, this is what it looks like. So it's our cookbook is what I call it. These things are more guides for me. They're not the Bible or anything. So they came up with cyclical mood disorder because we realized these kinds of disorders look very different in teens and children. In adults, maybe you're depressed for 3 months, then you're manic. And kids, it could be within a minute. I had one little boy who was laughing. While he laughing, he told me he was going to kill himself, and he was laughing while he said it. He could swing between minutes. It's helpful with data, kind of watching. We saw an inpatient year because it's great because we have behavioral psychologists, and they actually we can plot behaviors, and the behaviors can be cyclical. And there doesn't have to be a family, a mood disorder history. I think probably in SLO people are predisposed to mood disorders because of the cholesterol deficiency at the level of the brain. And these are some of the medicines we use for cyclical mood disorders. We use lithium. It's not my first choice because you have to get blood tests. And there's a small window between what's therapeutic and what's toxic, meaning what's going to work and what's going to make you really sick and dangerously sick. So it's not my first choice. It should be on the bottom of the list. But my first choice is Depakote. Usually I use that a lot. I tell parents, who knows what it's treating, but it treats everything. It treats seizures, it treats migraines, it treats mood disorders. it works. I can get a blood level, which is extremely helpful because as a psychiatrist, often it's like all our other medicines, like, well, we don't really know, what dose are we going to use? Do we go higher, come back in a month? We know we have an established blood level because it treats seizures, and seizures are easier. You're either seizing or you're not, as opposed to are you feeling more depressed, fuzzy stuff. So we do know that people with bipolar disorder need a higher blood level than seizures. I've had patients who their seizures are fine, but I have to push the blood level higher. And all the labs, even at Hopkins, say 50 to 100 is therapeutic. That's not what's therapeutic. It's like 75 to 125 or more, including for seizure disorders. The neurologist said no, but you get it anyway. So I get these patients coming to me, oh, I had a trial of Depakote. What was the blood level? 50. I'm like, no, you didn't have a good trial of Depakote. We need to go higher and try this again. Trileptal is another one. I don't use it as much. And the others, lamotrigine does work well. The other ones also happen to be seizure medicines as well, but we use them for mood disorders and instability. So ADHD, so definition, attention deficit hyperactivity disorder. It's very common in individuals who have mild SLO, particularly the boys that can be very active. And in typically developing individuals, boys are much more active than the girls. They used to think it goes away in the majority of people. Now we know it stays in probably 2/3 of individuals into any individual gets it into adulthood. Just often the overactivity lessens, but they still have attention difficulties. And how am I doing for time?
Just about out.
Okay, all right, very good, great. Okay, so Julia's going to talk about attention. I've gone over this, and in your slides, these are the meds. I just go over quickly. There's the stimulant family. Anyway, this is all in your slides. You're welcome to contact me. I do want to say I like guanfacine. I know I talked about it yesterday. Guanfacine and clonidine. It's a much lower side effect profile. They treat seizures. They treat high blood pressure. It helps anxiety as well as ADHD. There's a long-acting form if you can swallow a capsule. If not, you can use guanfacine, which is fine. You can use it once a day. Generally, we dose it twice a day. It's really nice for sleep. You can give it with clonidine in there. So you'll see that 0.1 milligram of clonidine is about equivalent to 1 milligram of guanfacine. And I can still come with Julia's time because I talked about behavior stuff. So, I do use them together. I look at those milligram amounts and it helps me with that. So this is a really great, so it's really hard for doctors. It's just like not in our Harriet Lane handbook and things that tell us low blood pressure norms. They have high blood pressure, what you're worried about. So this website, but I also printed it for you. And if your doctor takes a magnifying glass, you can see this pretty well. They can look and say, okay, I have a girl who is 10 years old, and I'm worried about my maybe 5th centile, that normal for the high number, like when you do a blood pressure, is going to be abnormally low is 84. And the lower number when you do, and then for, I'm not sure where I put that, but anyway, and then for boys and girls, what if I didn't do diastolic? But if you go to that website, you're able to print it, and I checked it, it still works. So that can give you your doctor to say, because I may have like a norm for, let's just see something for a second. Did I do? Yeah, I didn't do it correctly. Sorry, missing the diastolics. But I can email the file to anyone who emails me as well. Then you can send it to your doctor. So they can know that, for example, the child, that the higher numbers, like when you do blood pressure. So you want to do, if you're 6 years old, the higher number, the too low would be like 74. When an adult would be we'd be worried about that. Anyway, I send these to pediatricians and they go, oh, okay, I can go up on the dose. And our kids, if you can't get a blood pressure on our inpatient unit, we give it anyway. If you're not symptomatic, you look for, if you go from a sit to a stand or a lie to sit, do you look dizzy? Are they overly sleepy? Kids can tolerate these medicines really well. Sleep problems, the handbook, if you go to the toolkits, Google Autism Speaks toolkits, and you'll be able to download all these various things. There's a very nice one on sleep. There's one on melatonin. If you're using a sedating behavioral med, you can often give it in the evening to help the sleep. And the guanfacine and clonidine, I already just described that. Remeron, I don't use that as much. It can cause low blood cell count. Trazodone, although they use a lot in community, it increases 70HC pretty highly out of all the various meds that were tested, so I don't tend to use that. Hydroxyzine, which is an antihistamine, can increase 70HC. All right. Any questions for me? And I know we have one-on-one things anyway. Yeah.
That was wonderful. There might be some questions. I wonder if you and Dr. O'Connor could answer questions at the same time
Perfect.
after we have her come up.